Hi everyone, my name's Jenny and I'm the lead nurse for tissue viability and harm-free care at the Royal Marsden in London. The aims of the session this morning is to introduce some quality improvement techniques and give you my honest reflections of using these techniques in practice during my Darzi Fellowship year. Some of you may know I am a fan of social media, so I do encourage you to tweet away. My Twitter handle is MarsdenTVNs, how original. There's nothing confidential in my presentation, so feel free to take photos. So a good place to start would be, what is a Darzi Fellow? Now, a Darzi Fellow is a prestigious and high-profile initiative that spans a multidisciplinary team. It's funded by Health Education England and supported and delivered by both London South Bank University and the London Leadership Academy. And essentially, fellows are put into a new organisation for a year, funded to do a quality improvement project. Now, organisations sign up to have a Darzi Fellow because it gives them dedicated resource for a full year regarding quality improvement. And fellows sign up to become a Darzi Fellow because actually what it's designed to do is to develop already established clinicians into the senior leaders for the NHS in the future. When you're a Darzi Fellow, you go to London South Bank University part-time and you study a postgraduate certificate in leadership in healthcare. And in that, there's quality improvement elements. And it's bespoke for the Darzi Fellowship programme. Now, my project was to go to the Royal Marsden and reduce pressure ulcers by 15%. And that's hospital-acquired pressure ulcers. Now, that is one sentence, that was my aim, and how I achieved that was very much up to me. Now, a very simplistic definition of quality improvement is a systematic approach that uses specific techniques to improve the quality of healthcare. So a good place to start for me is to tell you what happened at the end of my Darzi Fellowship. Now, my aim was to reduce pressure ulcers by 15%. What we did achieve in a year is we increased pressure ulcer reporting by 46%. We reduced hospital-acquired pressure ulcers in the Royal Marsden by 42% in 1 year. Now, if you take the length of stay for a patient with a pressure ulcer on an average of 5 to 8 days, you combine that with the NHS Improvement 2018 productivity calculator. With our 42% reduction in pressure ulcers, we saved the Trust £334,000, and we also saved our patients 455 days of hospital stay. So that's 455 days our patients were at home with loved ones rather than with us in hospital. Now, people say, you know, how did you manage that? 46% is massive. How did you manage that in 1 year? And actually, the truthful answer is I have absolutely no idea. Absolutely no idea. And the problem with having a year's worth to improve something is you end up doing lots and lots of things. When you're working full-time as a tissue viability nurse or community nurse, practice nurse, you tend to only have capacity to do improvements for 1 or 2 small things at one time. So actually that's easier to measure than actually when you've got a whole year, you do lots of stuff and you're not sure what exactly your intervention made the impact to the reduction in pressure ulcers. So what we did do was, there was certainly an increase in multidisciplinary collaboration across the Trust. There was definitely a notable shift in culture, moving away from working in silos and very much towards a shared accountability and promoting a self-care model. We did lots of awareness events. We did a mock coroner's court and, of course, the Red Dot campaign. We carried out a prevalence and quality audit. which allowed us to look at the results and certainly focus in on very specific areas that needed improved in the hospitals. We introduced celebrating success. And yes, you might see it on social media, there's lots of cakes and balloons and certificates, but actually we celebrated ward areas that were doing really well with preventing pressure ulcers. But we also celebrated the wards that really struggled. We helped them to celebrate their success in improving their leadership around pressure ulcers. We also helped them to celebrate actually their effort and their teamwork around pressure ulcers. So celebrating success isn't just for the clinical areas that are preventing pressure ulcers, it's for the clinical areas as well that are working damn hard. The other thing that we did was we improved the quality of our data, so how we capture pressure ulcer data, and that allows us, again, to be more specific with our quality improvement. We did a lot of awareness and some staff education. We strengthened the Tissue Viability Champion Network within the Trust. We improved the governance around pressure ulcers, and we introduced more ambitious key performance indicators. We also introduced a new root cause analysis process. So actually, trying to measure which one of these activities reduced our pressure ulcers by 42% in 1 year, as you can see, is quite difficult. So one of the quality improvement approaches I used during my Darzi fellowship is called Appreciative Inquiry. Some of you might have heard of it. It was created by Cooper Ryder in the 80s, and he developed that to help organisations develop themselves. Now, Cooper Ryder and his colleagues found that excessive problem solving within organisations was actually counterproductive. They felt that actually continuously focusing on the problems and what's wrong with our organisation and focusing on things we're not doing well really prevents staff becoming innovative. The appreciative inquiry approach is very much aligned with the positive psychology and also a strengths-based approach. It very much promotes the quality improvement facilitator, guiding conversations very much away from the negative, what's broken, and into the looking at successes. So the way I interpreted that was very much to go into the Royal Marsden. I'm going to try this new technique because I'm a quality improvement facilitator now, and I'm going to ask all you guys, what's good here? What works? What are we doing well at? Can we have some more of that? That's how I interpreted appreciative inquiry. So actually, I used this at the very beginning of my Darzi Fellowship when I was new to the organisation. And I used this to frame my discussions and my conversations. And I did that on a one-to-one basis with staff. I did it in groups with staff based on their specialities. It might be a group of matrons, it might be a group of allied health professionals, for example, or clinical nurse specialists. And I also did open forum focus groups as well, so anybody could come and come together and have these conversations. Now, Cooper Ryder says to employ this approach, you have to progress through 4 levels to be able to say that you've applied appreciative inquiry. Now, there's 4 principles of AI. The first principle is discovery. That's where you're searching for the best in the people. What are people doing well? Why does it work? Why does it work here and doesn't work anywhere else? The dream stage is, rather than focusing on barriers, why things don't work and why we can't do it that way, is to encourage people to dream. Dream big. That's what we would refer to as blue sky thinking. Where's the gold standard? What can we achieve here without barriers or limitations? The design phase is actually when we start collectively creating our vision and creating that blue sky thinking. And the 4th stage is destiny or delivery, where staff are asked to commit to implement their gold standard. Now, my reflections on appreciative inquiry, I have to say, personally, it was not my favourite approach to quality improvement. I found the discovery stage quite labour-intensive, When you're in a room and you're new to the organisation and you're this change agent, people want to tell you what's wrong. They want to tell you what to fix. They want to tell you why it's wrong and who made it wrong. So it's very, very difficult to guide a conversation to be very much focused on the pros and the strengths. So in my opinion, I found that quite labour intensive. The dream stage, it's great to look at the ideal, but again, very labour intensive because people want to tell you about the barriers and the limitations and why you can't do that in this trust because so-and-so said, and that team doesn't work with that team. So actually, I found that, yes, the blue sky thinking was great, but actually I found it a bit of an anticlimax. The design stage was a very interesting one personally for me. And I think I became quite aware of my personal bias in that stage. Because actually I've been a tissue viability nurse for a number of years. And when there is a problem, I have fixed it in other organisations, and I think I know how to fix that problem. So I was very aware of my own personal bias coming into that. So that was quite enlightening for me. The fourth stage was the destiny. And actually that requires time and commitment to implement the blue sky thinking. And time and commitment is not something we have lots of in the NHS. So actually when we design things and then we asked staff to implement them, you would see the room disappear and the tumbleweed. So I found, on the whole, appreciative inquiry wouldn't be an approach that I would use as frequently as I would use other quality improvement approaches. On the plus side, because I was new to the organisation, using this approach did allow me to meet many, many stakeholders right across the organisation. And what I did like about it is actually when you put people in a room and ask them to blue sky think, it's very generative and it created interest in my project and it created engagement and intrigue. So people were interested in what we were doing. What it also allowed me to do as a leader was to conduct a thematic analysis. Now, a lot of the people I spoke to said similar things, whether that be it we've got an issue with equipment, or whether that be it we've got a moisture issue. There was very much themes throughout the conversations that I was able to grasp on and triangulate that with my gap analysis, and that gave me a good foundation going into that organisation on what needed to be done. Something I found, again, very intriguing was actually what I was observing in staff behaviours. What I found, certainly in my project, that what staff say and what staff do are two different things. So staff were very proactive in telling me that we are very collaborative, we work across a multidisciplinary team. Jenny, look at us, how great are we? And then you would walk into the staff cafeteria and you'd see one colour uniform there, the other colour uniform there, and the other colour uniform there. And you think, well, are we really collaborating across a multidisciplinary team? So it's just an insight that I found interesting during that approach. So the other approach that I used in my Darzi fellowship was co-production. Now, co-production originated in America in the 1970s. By Eleanor Ostrom. And she identified very much a disconnect between users of services and providers of services. For example, the police, the fire service, and healthcare as well. And she defined co-production as where both of these groups come together to shape and design the services that they're consuming. So essentially, patients in a hospital context, it would be the patients and the staff come together to co-produce what the services they're providing and what they're consuming. It was actually introduced to the NHS in the 1980s and seemed to disappear for some time and has made a resurgence in the last few years. In my opinion, when Professor Richards from the CQC said that the NHS in its current model is not capable of meeting the needs of this population. And also, you found co-production a year later and the next steps in the 5-year forward view. The document clearly states that improvement strategies should be co-produced. But is it just a buzzword? I hear the word co-production all the time. And I think it's become victim of being a buzzword. I think people use it for great intentions, but don't truly understand what it means. When I was studying co-production during the academic part of my Darzi Fellowship, I found that even the authors in the literature don't really know what it means, or they can't agree what it means. But what I did find is shared language. If you look at the literature in co-production, words like assets, shared power, and equal relationships all are recurring themes within the literature. Professor Malby believes that there's 3 levels of patient involvement. The highest level of patient engagement would be co-production, but she believes there's 3 levels, and no matter which way you look at it, co-production's the best. She describes the 3 levels being voice, choice, and co-production. Now, the voice stage is, we've probably all done this before, where we, for example, design a patient leaflet, and then we take it to patients and we ask them for their feedback. I think the most of us in our room has done something like that. Now, that would be the voice stage of patient engagement. The choice stage is obviously slightly improved on the voice stage, and that is where we ask patients to give their views, but also some decision-making as well. So to put that in context, if you were designing a new leg ulcer clinic, for example, you would invite your leg ulcer patients in to help design that leg ulcer clinic with their thoughts and opinions pivotal to that. The highest level of co-production is obviously at the top, and what that means is actually patients are there from the very, very beginning. And in true co-production, you don't know the answer. You've got an issue or you've got a problem and you want to fix it, but actually you don't know the answer. So that's why patients come in at day 1 and you figure out the answer together. What co-production's not is clear. And I think after a year, 18 months of practicing co-production, I'm just getting comfortable with it now because it's not comfortable. And that's the truth. Working with patients on an equal partnership with shared power is not comfortable. So we had, at the Royal Marsden, we had an internal pressure ulcer multidisciplinary collaborative group. And we knew we wanted to create a bedside tool of some description to help us prevent pressure ulcers at the bedside. So we developed an asking bundle, which you've heard about from previous speakers. But essentially, an asking bundle is a tool. It's a prescription of care at the bedside to prevent pressure ulcers. During our collaborative group, we invited patients from day 1. We had 4 patients that volunteered. One of those patients actually had a pressure ulcer in the Royal Marsden, and that's the reason she was keen to join our group. One of the other patients, her mum was one of our patients, and she was admitted to the Marsden with a significant pressure ulcer from the community. So she was coming in very much from the carers aspect. So we had 4 patients in our group. And certainly from my reflections, I certainly felt there's a shift in the power and control. As a senior nurse, I'm used to leading meetings and I'm used to guiding conversations in a specified time frame that you have that room meeting booked for. And when you do co-production, it does take longer. And actually, the conversations they do meander a lot more than you would think. And actually, I had to be quite mindful of my role here. If I was truly going to embrace shared power and shared accountability and control, I had to take a step back from being chair and leader into what, let's say, a facilitator, but not in a hierarchical sense. Everybody in that room, to achieve co-production, there has to be no hierarchy. Actually, like I say, in summary about co-production, it does take longer, but the journey's worth it. I absolutely believe co-production is a way forward. The asking bundle that we created is very rich, and it positively surprised me how rich it is. And when I look at it now, I can hear the patient stories. I can see why the asking bundle is the way it is based on the patients and what they've told us. We are actually publishing in the journal, the Wound Care Today journal, with our patients. That should be available probably next week. Our patients have actually not only co-produced the asking bundle, we're co-publishing with our patients too. Now, in summary, I wanted to have some top tips and try to squeeze them into one slide if you were to start a quality improvement project. So my first top tip would be to find your people. And your people are the people that you bounce off, the people that excite you, the people in the organisation that want to do well, that are motivated and excited. And don't be surprised about the people who are your people. Actually, during my Darzi fellowship, it was occupational therapy and physiotherapists that actually were my biggest supporters. So don't be surprised that your people are not necessarily where you think you might find them in the organisation. My second top tip would be to listen with your eyes. Like I said, staff say things and then they do something completely different. So watch, use your eyes, and that will tell you exactly what you need to know. Embrace the fear and smile at the confusion. Now, going into a new organisation as a change agent, change is frightening. People don't like change. It's uncomfortable doing change. It's uncomfortable facilitating change. So just smile at the confusion and embrace the people that are struggling with that, and just give them the time to come to terms with what's happening. It's definitely worth it. Failure. Now, in quality improvement, some projects that you do will work exceptionally well, and some projects that you do will fail. And I think it's the understanding and knowing that not everything in quality improvement works, and actually it's how you fail, how well you fail. If you're going to fail, do it well. And actually what you want to do is you want to learn from that failure. You want to dissect it. You want to explore it. You want to learn from it. Just own it. My other top tip would be aware of your own and others' bias. Like I say, coming as a tissue viability specialist of several years, I thought I had my own ideas that what worked. And actually just learning that my bias can be counterproductive. Am I okay? Yeah. Okay, I'll skip on to the next one. Joy in work. Now, if many of you follow me on social media, you'll see that I tend to like to dress up and have some fun and put some crazy pictures on social media. Now, actually, people think we're having a great time, and we absolutely are, but there's always method to my madness. And joy in work, I certainly wouldn't underestimate it. You might see us on Twitter going round with red dots or dressed in pyjamas, but actually don't underestimate joy in resilience of staff. And team building as well. And also, people get tired of change. We call it change fatigue. So for all these things, joy certainly helps. So don't underestimate joy in the workplace. Certainly, I like to plan in advance for joy, but also have a stat dose just ready to prescribe at any time if you're having a low point in your quality improvement projects. Now, my last point is your next speaker is going to tell you about the National Strategy in Wound Care for NHS England. And my last top tip would be the strategy's coming, and everybody in this room are key enablers for that. And so if you don't have quality improvement skills or you don't have quality improvement knowledge, I would get ready because the national strategy is coming. Thank you.